Good morning. Happy Tuesday. Welcome back to Teach Me Tuesday, where today we are doing NRP part 3 of 4. It's like our December to remember. I'm like excited that this worked out perfectly for 4 Tuesdays for this month. So today we are going to just take a little bit of a deeper dive into kind of what happens when the code continues to go on, or the code is in the NICU and not in the delivery room. So just a little bit further in those NRP steps, an algorithm, and a little bit of an overview of that. So let's begin by just kind of reviewing the basis of NRP. It's this well-established program with a focus on teamwork to bring safe and effective care. So again, all of this is evidence-based practice. And while maybe you're at a facility that doesn't have deliveries, whether you're at a children's hospital or a smaller hospital, or maybe you have like a delivery and admission team, you don't go to deliveries, and you're taking these NRP classes and you're like, how is this like applying to my everyday life and what I do in the NICU? It does still take that same algorithm and apply it no matter where a baby is coding. So we use that algorithm, and then sometimes we do have to go beyond those basics. And I'm going to go into that a little bit in some of our final slides here on this slide deck, but really thinking, what do those basic steps of NRP tell me about teamwork, about working together, about what next steps would look like in a NICU? And really, when we get towards those ethical issues, other medications, all of it is kind of building together when you put those little puzzle pieces together to complete your puzzle. So let's talk about our key takeaways from our two previous slide decks. So if you haven't watched those NRP part 1 or NRP part 2, I recommend kind of going back and checking those out. But the things that we have talked about so far, just like a few quick items. Thermoregulation. It starts from the beginning. The minute the baby comes out, we are warm, dry stimming. We are placing in a plastic poncho of some type. We are getting the baby in warm blankets. We are getting the baby skin to skin. That's true no matter if you have a preterm baby, a term baby, a healthy baby who requires no resuscitation, or a baby requiring full resuscitation. Thermoregulation, it should drive every decision thereafter. From there, we are looking at ventilation. Remember, NRP tells us, is the baby vigorous? The sign of vigor is breathing or crying, heart rate greater than 100, and tone. So if we have those things, we can do delayed cord clamping. We can do skin to skin on mom. We could never touch the baby if we're the NICU team there for delivery, right? And then from there, we take this teamwork together with role identification to decide what do we need to do next. So in the setting that the baby is not breathing, our indications for ventilation, which would be positive pressure ventilation, are apnea, gasping, or heart rate less than 100. So if those things are happening, we are going to be moving ourselves down that NRP algorithm. And in order to do that, we have to have effective teamwork. We need to identify roles. Who's our clear leader? Who's going to be providing PPV? Who's checking the heart rate and getting the oximeter on the right wrist? What are we doing in those circumstances so that we can effectively help this baby? Remember, the single most important thing we can do to avoid those next steps of the algorithm is effective ventilation. From there, we may need to do compressions, right? If our heart rate is less than 60 despite effective ventilation, which is you got your chest rising, but your heart rate still isn't coming up, we might need to begin compressions. We move on to our medications, where primarily we are giving epinephrine and normal saline or LR, or maybe blood in a delivery room setting. From there, we need to get access, and then be sure we are documenting what we are doing. So that's what we've kind of covered in our two slide decks. That's our initial steps, our next steps, if our code is going on, if ventilation is not getting our baby out. So from there, what do we do if our code continues to go on? So what is a prolonged code? So NRP is guiding us to check that heart rate every 1 minute. We also, if we have gotten to the step of alternative airway, and especially if we are doing compressions, we should have placed cardiac leads on the baby by now. So yes, we started with our oximeter on our right wrist, but as you know, if a baby has really poor perfusion, which can happen at birth and especially during a code, that oximeter may not be picking up well. So we need to consider another way of confirming what the baby's heart rate is. So we could go and get our monitor. Some delivery services have that in every room. Maybe you need to go grab them from a hallway. Whatever it is, we need to get that heart rate monitor on our leads. However, during compressions, we really can't rely on what that monitor is telling us. Many monitors will pick up your compression rate and it'll say that you're compressing, your heart rate's 90, but really that's because of some of your compressions. So every 1 minute we should pause, do a 6-second check of the heart rate. It's a great time to switch your compressors. So remember, we as the compressors are getting tired and having this hard time because of the talking and what we're doing. And adults talk about the physical labor of doing chest compressions, but with the babies, it's that breathe, or 1 and 2 and 3 and breathe in, 1 and 2 and 3 and breathe in. It's a lot of talking. It's also emotionally taxing to be doing this on a baby, so great time to switch someone out. The documenter should stay consistent. This is the person that's telling you, it's been 1 minute, let's check the heart rate. It's been 3 minutes, it's time for another dose of Epi. The documenter needs to be able to know what's going on and to be able to speak up and say, this is what we need to do next. The clear leader should continue to seek recommendations from the rest of the team. So anytime you've been in a prolonged code where maybe we've given a couple doses of Epi, a bolus, you will often see a leader say, like, what else should we consider? Are we missing something? Was there a bleeding risk? Do we know our access is great? Is our tube still in a good spot? Looking kind of to the team, like, is there anything else we've forgotten? Because that is what we want to do. We want to make sure that we have kind of caught all of the things that we need to during this prolonged code. So these are those things that as you continue to go on and you've kind of gotten out of that 5-minute window, you're approaching the 10-minute window, maybe even past the 10 minutes. These are the things that you should be hearing when you approach a room or you're in the room or you're one of the compressors is, it's been 1 minute, we need to change compressors. The documenter being consistent and talking out loud, and the clear leader seeking input from the rest of the team. Because what teamwork tells us during a prolonged code is that we need to have situational awareness. What happened? What preceded this event? Whether that was an abruption, the fact that we're just a 22-weeker, the 3-month-old in the NICU. We need to have collaboration. What have you seen? Have you considered this? Have we tried this? That closed loop communication. This is 0.5 mils of epinephrine for the UVC. I'm giving 0.5 mils of epinephrine for the UVC, our dose, our route, our medication. Delegation. Really, as people are coming and we have identified the roles, we've done our role identification, whether that's in roll cards or badges that you wear or lanyards that you put on, is somebody really being like, okay, you're going to be in charge of this. You're going to document. You're going to do this. I need this supply from the supply room. Psychological safety is that ability to speak up when you're seeing something that's wrong or to just make a suggestion. For instance, I know one of the things that I often do when I go into a code in the NICU is say, are we on 100%? Because if we are doing compressions, NRP tells us in the algorithm that we should be on 100%. And oftentimes that's just something that's missed. Or if you have specialty mattresses or positioning devices, have we removed those from under the baby? Have we placed a backboard? Just those things that sometimes in the moment we kind of forget about. So having the psychological safety to know, like, hey, I'm making this suggestion and it's going to be well received. We've talked about role identification. Oh, I put closed loop communication on there twice. I must have thought it was super important. So that can also happen with your compressions. It can happen with your person that you're doing the PPV and the compressions with. So there's lots of opportunities for closed loop communication, not just in the medications. It can also be in the, if I'm the person delegating out and I say, I need a porta warmer, the baby's getting cold. The other person saying, I'm going to get the porta warmer. When they come back, here's the porta warmer. So then we know that the task has been completed. That's also an example of closed loop communication. And just in the shared mental model of like, have we tried everything? Do we know what our endpoint is? Do we know what the parents want? What were the parents' wishes for their baby? And if not, have we gotten them on the phone? So this teamwork really leads to these keys here, right? So if we want to have effective teamwork, we need to make sure everyone is familiar with our resuscitation equipment. So that's your bedside safety checks at the beginning of every shift. That's doing mock codes. That's going to NRP class. That's practicing with it whenever you can. You can do it on a mannequin. You can do it in an education class. Being prepared to adapt to those changing circumstances. We don't always know what the baby's going to do or how they are going to respond. Flexibility, collaborative environment, open communication, mutual respect that comes along with that psychological safety, and then the emotional support at the end, encouraging the open communication about the experience, about what just happened. In our fourth and final slide deck, in our fourth part of this NRP series we've been doing in December, we are going to talk about debriefing and how important it is. NRP tells us it's important, but what we know about debriefing and how that enhances our environment and our nursing staff and our medical staff, and how debriefing allows us to identify gaps and then make changes. And it's not just clinical, it's kind of the emotional part of it too. So it also is helping us to foster that collaborative environment. I'm already going into debriefing because I love it almost as much as simulation and the placenta. So, I like it a lot. Sometimes in our prolonged codes, especially in our older babies, we may have this situation where we're giving medications that are kind of outside the normal NRP medications. In our unit, we are only NRP certified. Our 200 plus nursing staff, we do not carry our PALs. I know that there are places, I've read on the NAN forums, that only carry PALs and don't carry NRP. I know that there are places that carry both. We do have PAL certified nurses in our transport team, some of our respiratory therapists, our providers, etc. We also have a PICU, right? So we are in a place that if we need to go on and use outside medications, we may be calling on our PICU team to be coming down and helping us, or our transport team to be helping us. But these are some of those medications that you may see during a prolonged code. Sodium bicarbonate, I think we all know that that's really helping with some of that metabolic acidosis when our babies are in severe respiratory distress. Naloxone, we've given that probably 2 times this year. Really, that's if for whatever the opioids the mom has taken or been given during her delivery. And so the baby is coming out in respiratory distress, and how can we reverse that? Surfactant may not be given right away during a code, but immediately thereafter in the delivery room, something that we're giving to try to give the baby the best chance at their respiratory support. Calcium gluconate, so this is going to help a lot with our cardiovascular function. So these might just be medications that, the NRP book doesn't cover, but things that you may see during a code or a prolonged code of your baby. As we are doing these prolonged codes, some of the things that come up is kind of, hey, how long should we be doing codes? What is going on? What is the guiding principles of the length of a code? In the 8th edition of the NRP book, they talk about the 20 minutes of kind of being like, hey, this is how long this is going on. Previously, they had talked about 10 minutes, and then with the advancements of total body cooling, they said, hey, we should really consider doing this up into 20 minutes. In my opinion, unless there's been a pre-discussion with the parents, the baby's in the NICU and is in a DNR, codes typically last 20 to 30 minutes. That's kind of what I've seen throughout my experience over the last 20 years. So this didn't feel like a big change, but really what it kind of tells us is it's going to take 20 minutes to feel like you've kind of done everything that you can to help this baby if that is what the parents wish. The other things that we have to take in mind when we're thinking of these ethical issues is extreme prematurity. So those babies that are less than 24 weeks, especially between 22 and 24 weeks, is really having that discussion with the parents on how much they want us to do. I was in a 22-week delivery recently, and it was, the parents were like, yes, I would want you to intubate the baby, but I don't want to get to the place where we're doing chest compressions. We cannot always have those conversations. Moms precipitously deliver. They show up at the hospital complete and pushing, right? We can't always know. So it's kind of figuring out, what are we doing? What is the guiding principles of what we've done here, and how much more can we do? With our trisomies, if you have a fetal care team or a team that sees these moms prior to delivery, they usually have a kind of a plan of what they want. But many of these trisomies are incompatible with life, and so it's how much do they want us to do in the delivery room. Our congenital anomalies, anything from severe diaphragmatic hernias to severe cardiac anomalies, is what is kind of the best thing we can do, right? If you're talking about a diaphragmatic hernia, that baby comes out, we're going to want to get them intubated, and we don't want to be doing a ton of PPV, so we're not getting too much air into their belly. So thinking about that even before the resuscitation begins. If mom has prolonged rupture of membranes, maybe she's been ruptured for 18 weeks and now she's delivering at 26, 27 weeks. What kind of lungs are we going to see in this baby, right? Fluids is kind of what's growing our lungs. And in the absence of fluid, how well is this baby going to be able to ventilate? If the mom hemorrhaged, how quickly do we need to get blood back into this baby? What was the baby experiencing if she hemorrhaged? We had a mom, this was a few years ago, that had a placental abruption at home. So what length of time was that baby without blood, right? These are all different things that we need to consider as we are going through the resuscitation of this baby. These are not easy subjects. I don't want to just kind of be glossing over and act like, oh yeah, these are the easiest conversations we have, because they're not. These are some of the hardest things that we do in the NICU, and having kind of a pre-plan is always going to help us, but we don't always know. So in those situations, we are just going to follow our NRP algorithm and do the best that we can with the information that we have and what the parents are asking of us. When we talk about NRP in the NICU specifically, it can feel a little bit different. But if you think about the guiding principles, and what really needs to come back here is the difference between oxygenation and ventilation, which was my very first Teach Me Tuesday that we put out. So there is a YouTube video about that. But you need to look at the baby. If the baby, you're in the NICU, your monitor goes off, you go into the room, you see the baby's heart rate is this, or the saturations are this. If your heart rate is less than 100, if your saturations are dropping, it's looking at the baby and looking, are they breathing? Is their heart rate less than 100? Are they gasping? If your baby is not breathing, you're going to do those same steps that you would do at a delivery. At a delivery, we call it warm, dry, stim, right? In the NICU, we're going to start with some light tactile stimulation. Most babies are going to come right out after that. The important thing to consider is if the baby is not breathing, we can't just give them some flow by or blow by oxygen because they're not breathing. So that's not going to help them with anything. We need to get them breathing first. From there, we would just progress down the same algorithm. We've tried some light stim. Maybe we've sat you up and tried a little bit more. If we aren't there, it's been 15 seconds, 30 seconds, we need to be giving PPV, positive pressure ventilation, using the steps of Mr. Sopa to get us through there. If you are getting to the P of Mr. Sopa as a bedside nurse in the NICU, you need to be hitting your code button, right? We need more people to gather because we are not going to be intubating unless that's something that you do in your unit. We need somebody there to do that A of Mr. Sopa, our alternative airway. Then we need to decide intubation versus compressions. We've talked about that during our last Teach Me Tuesday, this idea of if a provider is present, we are going to intubate prior to starting compressions. But if your provider is at another delivery, if they're not in the unit at the time, if they're on their way there, beginning those compressions if the heart rate's been less than 60 despite positive pressure ventilation. And then going to your medications and your documentation. All of these steps are, yes, feel very similar to what you're doing in a delivery. However, in the NICU setting, it's just stimming the baby, watching for, are they breathing? So the oxygenation versus the ventilation. And then from there, following your same steps of knowing what to do next. So today we are taking that standard approach of NRP in the delivery room and stretching our knowledge to what we can do when we have prolonged codes, when we have codes in the NICU, when we have things outside of that standard kind of delivery setting. And if we just think of the algorithm as a guiding principle of what to do next, we will be able to provide safe and quality care to these babies. So thinking about what does the baby need? How can I best help the baby? Are they breathing? Beginning my ventilation, Mr. Sopa, Mr. Sopa, Mr. Sopa. If my heart rate isn't rising, I need to try something different. And from there, you will then gather your team, do your role identification, get everyone assigned their roles, and you will be able to effectively resuscitate these babies. Next week, we're going to talk about what happens when things don't go as we planned. What does simulation look like to help coordinate all of this NRP business? And then what is debriefing in the NICU? So if you're watching this, next Tuesday we will be after Christmas. If that's something that you celebrate, have a great holiday season, and I will see you next Tuesday for the final edition of NRP Strategies for Success.